Good morning, everyone. Thank you for the opportunity to the judges for having selected my video in the final session. I would like to play the video now. Volume, please.
65-year-old gentleman came with a significant pseudoexfoliation and grade 4 posterior subcapsular cataract. The AC depth in the eye to be operated was significantly lower than the other eye.
I've just paused the video.
As I began the case, I realized that the pupil was not that well dilating and the AC was quite shallow. I stained the anterior capsule in the hope to get a better view. As I injected the viscoelastic, I realized that the pupil was not going to yield more than around 4 millimeters. I decided to use the first weapon in my armamentarium, and that was the Malikan ring. As I began inserting the Malikan ring, it became evident that the AC being shallow, it would be difficult to engage more than one scroll. And using the Kruglan's hook, I engaged the remaining scrolls with the help of two Kruglan's hooks. It is quite an traumatic procedure to use the Kruglan's hook to engage the scrolls within the margins of the pupil. As I began the capsular excess with the help of my cystitome, I realized that I could not take the first nick within the capsule. With the cystitome, the whole lens and the capsular bag kept moving side to side. This was my second clue that yes, the zonules are weak all around. I injected some viscoelastic to try and flatten the anterior capsule, and at this point I had my first breakthrough. I could finally raise a flap to begin the capsular excess. As I went ahead with the anti-clockwise direction of capsular excess, I realized that I was not able to proceed ahead smoothly. So I went in with my micro-excess forceps to continue the capsular excess. When I reached the nasal quadrant, I realized that I was causing an undue pull on the zonules. So I decided to use one more micro-excess forceps to try and stabilize the edge of the CCC and proceed ahead. I refilled the anterior chamber and with my right hand proceeded with the capsular excess using the micro-excess forceps. A change of direction was again important, and going in with my left hand, I managed to complete the rexus well. A good hydrodissection, and before I began the management of the nucleus, I decided to use the capsular hooks to support the bag which had zonular weakness in all the directions. Once all the hooks are in place, the bag has a good anterior-posterior support. I began the nucleus management and chose the stop and chop method since the nucleus was pretty soft. As I proceeded ahead, I realized that it was difficult to crack the soft nucleus and I was struggling to get one edge up. Too much manipulation would have caused more harm, hence I decided to stop and go ahead and insert the capsular tension ring to provide an equatorial support to the capsular bag. I went ahead with the manual technique of inserting the CTR with the help of a Sinski's hook. I carefully inserted the trailing part into the capsular bag. I proceeded ahead with the phacoemulsification carefully, finally managing to get one edge up and tried to eat up the remaining nucleus and epinucleus. Once the last bit of the epinucleus was eaten up, I heaved a sigh of relief. For management of the cortex removal, I used the bimanual technique. As I began the cortex aspiration, I realized that the cortical fibers were quite sticky, and the capsular tension ring was going to make it all the more difficult to shear off these sticky cortical fibers from the surface of the capsule. I used the tangential method to pull out the cortical fibers slowly and carefully, trying to minimize the damage to the zonules. Using the hydrating currents, I separated more of the cortical fibers from the posterior surface and managed to clear up the bag of the remaining sticky cortical fibers. Once all the cortical fibers were out, I decided to get rid of the capsular hooks. And as planned, I decided to go ahead with the implantation of the intraocular lens, which was a 3-piece IOL. The leading haptic got a bit entangled into the Maligan ring and I had to carefully release it. After putting some viscoelastic, I manipulated with my right hand to dial the trailing haptic into the bag. I repositioned the Maligan ring and dial the remaining haptic into the bag. Now, using 2 Kruglin's hook, I disengaged the scrolls of the Maligan ring and took it out using the hook of the injector system. The anterior chamber was cleared of viscoelastic and the wounds were hydrated to complete the case. The take-home message in this case is, when faced with the challenge, it is important to use all the correct instruments and the right technique to complete the case without further complicating it and to emerge as a winner. Thank you.
Thank you, sir.
Thank you, Anushree. Excellent video. And I'll just highlight the wonderful use of the 2 hands as well as the 2 forceps that you used to bring that nearly running away rexis again into the focus. So that was an excellent use, and I think most of us are using this, but it's a very good use of your technique. I have 2 questions for you. One question is, knowing that it is a mid-dilated pupil, would you have thought that you can get a rexis in this mid-dilated pupil, adequate size 6, and then instead of putting the Maligan ring, which is quite a bulky ring, place in maybe the iris hooks itself, and or stay, and then once you have done the capsular rexis, then put in the capsular hooks. So the capsular hooks take care both of the iris as well as the capsule. That is one thing that I have in mind, a small question for you. The second question is that with this amount of zonulopathy, CTR well in place, absolutely fine. On the table, everything is well in place, it's well centered, but it might progress. So would you not have better anchoraged with AMET segments on either side, so that that stability, and of course with the newly used the Gore-Tex sutures now. So these are the 2 questions that I would like you to clarify.
Right, sir. So when I began the case, I was not expecting the zonulopathy to be so bad. It was only at the back of my mind that, okay, as I showed in the initial part of the video, the AC depth was different in both eyes, and there was slight, I felt that this could be, phacodonosis could be there in this patient. So I have to be more careful and prepared. When I went in, the pupil was mid-dilating, and I had not really thought that I'm going to use capsular hooks ahead. So I am more comfortable using Maligan ring because you're making less incisions, lesser time is required. And because the AC was not very shallow, I thought Maligan ring is not a bad idea to go for this case. And there was a fluttering of the iris when I began. So I thought that it might be little IFIS component may be there. So in that, I always prefer the Maligan ring. So that's how I began the case. And using the iris hooks later on, after the rexis is made, is a bad choice, because what happens is sometimes the iris hooks can tear the capsular edge. So yeah, right. So capsular hooks, because it came as a second thing, so I thought let me continue with the Maligan ring in place, use the capsular hooks to give the anterior posterior support. So your second question was? Anchorage. So as I did the case, if you noticed, only during the rexis I had the issue of the problem where, you know, the zonuolopathy was troubling me. So I thought it was more of an anterior weakness of the zonules, and the equatorial and posterior probably were not bad because the PC didn't come up. After I finished my phacoemulsification and during cortex aspiration, it was the CTR which was troubling the cortex aspiration. The PC was not bulging up too much. So I thought that, you know, I will get away with this, and the cataract was also soft. So I didn't, you know, induce more zonulopathy when doing the phacoemulsification. That's why I thought that CTR, 360-degree support, will be good enough for this patient. He was a 65-year-old.
But wait, the progress of a
Yeah.
zonulopathy
Yes, sir.
is
Yes, sir.
what
Right, sir. So you're absolutely right. That is the next management line. Yeah.
Thank you very much, Manish. Yeah, let's go ahead with the next one.
Dr. Ramya. Dr. Anubhav Goyal, is he here? Dr. Sheshir Varghese.
Please connect the audio also. So thank you KSOS for giving me this opportunity to present my video.
Pick and peel. Diabetic retinopathy is the leading cause of visual loss in elderly and working age population. It affects the retinal microvasculature, causing multiple progressive changes leading to the proliferative stage, which requires treatment. In PDR, new vessels grow using posterior hyaloid as scaffold. They progress to form contractile and vascular epiretinal membranes. Membranes contract and give rise to tractional detachments. Breaks develop and give rise to combined detachments. Diabetic vitrectomy is the standard treatment for several complications of PDR, with multiple studies showing its requirement and benefit, especially with small gauge instrumentation. The indications are vitreous hemorrhage, macular TRD, combined RD, progressive fibrovascularization, refractory DME, opacified posterior hyaloid and macular traction. The advent of micro-incision vitrectomy surgery has given us small gauge ports and cutters, the handle or needle pick, forceps, endo-scissors and diathermy. Preoperative anti-VEGF reduces intraoperative bleeding. Dissection plane should be identified correctly with identification of second membranes. It's easier to cut around the tractional points of these membranes. Intravitreal Avastin given 3 to 4 days prior to surgery reduces vascularity of membranes. In this case, preoperative Avastin given 3 days before surgery decreased the vascularity, making the surgery easier. Very minimal bleeding was encountered while dissecting the membrane. In this case, the dissection was carried out only with the cutter. After completion of membrane peeling, an ILM peeling was done, followed by fluid air exchange. This second case highlights the importance of identifying second membranes so as to enter a proper plane of dissection. Small gauge instruments like 25 and 27 gauge have revolutionized the way we manage diabetic tractional detachments. The small size of the cutters enables it to go under small crevices, thereby enabling membrane segmentation and delamination. The small sphere of influence of the cutter avoids the retinal tissue being engaged during delamination. In this case, a forceps is used to lift the membrane from the optic disc so as to create a plane for dissection from the center to the periphery. With the port near the cutter tip, it's easier to grasp and dissect membranes. With membranes over a mobile retina, the tandem use of cutter and scissors ensures its complete removal. The case is closed with only a fluid air exchange. Our fourth case had focal membranes with strong attachments. Dissection was carried initially from the center to the periphery. This case highlights the use of a pick and scissors for the delamination of a flat membrane with a strong focal attachment. This technique avoids unwanted retinal breaks. After removal of the membrane, a peripheral PVD induction is continued. An ILM peeling was done, followed by fluid air exchange. In our fifth case, we encounter an opacified hyaloid face and a pick is used to create a rent in the hyaloid, followed by residual dissection with a cutter. The beveled edge of the cutter can be used for the blunt dissection of membranes. In this case, we removed the second membrane using the cutter. In addition to diabetic membranes, this case also had a full thickness macular hole. Following removal of all traction, an ILM peel and inverted ILM graft was performed, followed by fluid air exchange and silicone oil injection. Occasionally, adherent membranes cause retinal breaks due to traction, and dissection close to it should be carried out carefully without causing further traction and enlargement of the break. Here we use scissors to gently delaminate the membranes. All traction is removed around the breaks. This is followed up by ILM peeling, fluid air exchange and silicone oil injection. Bimanual dissection is rarely used to dissect thick and highly vascular membranes. A chandelier light source is used for illumination. A cutter or scissors is used to dissect these thick membranes. Care has to be taken to lift the membranes very gently and cut the vascular epicenters one by one. Diathermy of bleeders also has to be performed. After removal of all attachments, the thick membrane is lifted with the cutter and removed. Heme is aspirated and bleeders are cauterized. Finally, a fluid air exchange and silicone oil injection is done. In our final case of combined RD, a cutter and scissors is being used to segment and delaminate the membranes. Low flow rate of small gauge cutters prevents the mobile retinal tissue being engaged in the cutter. PFCL is used to flatten the retina, followed by ILM peeling, fluid air exchange and silicone oil injection. A combination of the mentioned techniques have helped us to achieve success in about 90% of complex diabetic tractional detachments. Surgical outcomes have improved in PDR due to better vitrectomy machines, small gauge instrumentation, and wide angle viewing systems. To conclude, anti-VEGF injections, small gauge instrumentation, identification of second membranes, and membrane dissection in the correct plane along with patients can help in achieving good results. Thank you.
Shishir, very nice videos, Shishir, and an excellent demonstration of excellent techniques. So I have just two questions for you. One, Shishir, is that you went into great amount of patience and very patiently delaminating the membranes. What I felt is you definitely went beyond the posterior pole to quite some way beyond. So leaving certain amount of membrane and stumps without doing too much of dissection aggressively, which might compromise the attached retina and have iatrogenic holes. That was one thought of mine. The other one in which you had severe diabetic retinopathy with, I'm sure, macular edema and the membranes all sitting on the macula. You had a macular hole which you detected, and you repaired the macular hole. So here again, understanding that it is vasculopathy, which is the diabetic retinopathy, and in any way it is deeply compromised. So would you think we would serve any special benefits by putting in, repairing the macular hole with stuffing the membrane?
So usually the hole was very large on the pre-op OCT. So if I just remove the traction, the hole has a high chance of closing itself on its own, but I didn't want to leave it to chance. So I just wanted to, because it was a large hole, I just did an inverted ILM flap and wanted to close it.
The other thing, it's an excellent video, a teaching video. What I would suggest is, if you can re-edit it and it would become even more valuable, is the pre-op photograph you give, that video, the surgical video you give, and then the post-op photograph, and ultimately when all your teaching points are there, as a take-home message, pre-op, a small part of the video which can come in, and then the post-op with the OCT. So it gives a very hammering effect, as a take-home message. Excellent video, Shishir.
Thank you, sir.
Now I would like to invite Dr. Ramya, and she will be presenting a video on a rare case of a spontaneous resolution of an indirect carotico-cavernous fistula. Timely intervention preserved the vision and salvaged the eye.
At the outset, I would like to thank KSOS for giving me this opportunity and selecting my video for this prestigious Tony Fernandez Video Awards. Audio, please. Spontaneous resolution of an indirect carotico-cavernous fistula. Timely intervention restored the vision and salvaged the eye. A 51-year-old diabetic patient came to us with complaints of persistent redness in his left eye, which was treated as conjunctivitis for the past 1 month. He also complained of intermittent double vision on his left gaze. Why? It's not playing. Audio, please. A 54-year-old male diabetic patient came to us with first part from the first. Spontaneous resolution of an indirect carotico-cavernous fistula. Timely intervention restored the vision and salvaged the eye. A 51-year-old diabetic patient came to us with complaints of persistent redness in his left eye, which was treated as conjunctivitis for the past 1 month. He also complained of intermittent double vision on his left gaze. There was corkscrew-shaped vessels in his left eye, and on cover test, there was a left intermittent esotropia suggestive of left lateral rectus paresis. So, and he had a mild axial proptosis and a subtle abduction deficit in the left eye. Suspecting a carotico-cavernous fistula, I have advised the patient for MRI with MRA, and that was suggestive of an increased SOV enlargement, and then they go ahead with the suspecting CCF, they go ahead with the digital subtraction angiography, which showed a communication between the right internal carotid artery and the left cavernous sinus, suggestive of a Barrow's type B indirect carotico-cavernous fistula. This is the fistula showed in the right carotico-cavernous. This is the AP, and the other one is a lateral view showing the CCF. So the patient has been advised endovascular coagulation from the department, and but the patient deferred. So, and the patient was prophylactically started on anti-glaucoma medications. When he presented, the vision was 6/9 at the first visit. But after a few weeks, he presented like this. So when I asked the history, he said he went to many other places, and at last he ended up in the neuroradiology department, and they done the transorbital Doppler, which showed complete thrombosis of the superior ophthalmic vein. Since there was no carotico-cavernous reflux, so they told it the fistula was closed spontaneously, but because of the acute thrombosis, the patient has presented with a sudden acute proptosis of the eye with frozen eye, extraocular movements, and only the central 1/3 of the cornea was seen, and there was exposure keratopathy. On examination, he had a mild elevation of the disc, and suggesting an impending optic nerve dysfunction or central retinal vein occlusion. So in this case, we have to salvage the eye. That is the most important in this step, otherwise the patient will lose the vision. So we went ahead with the lateral cantholysis and canthotomy to reduce the intraorbital compartment syndrome and to save the eye. So, and since there was thrombosis of the superior ophthalmic vein, we have to prevent the carotico-cavernous thrombosis also. So the patient has been previously started on subcutaneous heparin 6000 international unit 6th hourly. We had stopped it for 2 days and went ahead with the lateral canthotomy with the cantholysis. And there was severe resistance to the retropulsion on table. So infiltrative anesthesia was given to the lid, and the artery forceps was placed at the lateral orbital margin, and the cut is given from the lateral canthus to the lateral orbital rim. It's a simple procedure actually, and vision saving as well as eye saving. So the lateral canthal tendon, it is cut, the inferior crest of the lateral canthal tendon is cut, and the intraorbital pressure is reduced. But even after this, the patient had severe resistance to retropulsion. So to protect the cornea, we did a lateral tarsal is cut into the anterior and posterior lamellae. Then So through the bolster, that's 4 millimeter above the lid margin, then through the gray line, then the same is taken through the gray line, 4 millimeter below the lower lid margin, and through the bolster and tied. And after 2 weeks, and at that point the vision was 660 and there was some disc elevation also. So post-operative after 1 week the proptosis has reduced and also the chemosis and the extraocular movements also somewhat recovered. And the cornea is now visible. Previously it was only 1/3 portion was visible. It is fully covered and there was thickened keratinized conjunctiva. So after 2 weeks, almost the eye looks quiet only with a mild chemosis and extraocular movements was almost fully recovered. The 9 case photographs you can see fully recovered. So in this case, a combined treatment of lateral cantholysis, tarsorrhaphy, a subcutaneous anticoagulation using heparin and anti-glaucoma medication saved the patient's eye as well as vision. And he's restored his vision back to 6/9. Thank you.
Excellent video. So what was the duration of this much of chemosis? Was it before?
No, sir. When the initial visit, there was very mild axial proptosis. Only
Okay.
in the case we could able to make out an axial proptosis. But he suddenly presented within 1 week with a sudden acute proptosis. That time he was in another place in the neuroradiology department. Then they did the transorbital Doppler. Previously there was only partial thrombosis of the superior ophthalmic vein. But when they did the transorbital Doppler, there was complete thrombosis of the superior ophthalmic vein and there was no reflex from the carotid to the cavernous sinus. So there was a functional closure of the carotico-cavernous fistula. At that point, they suggested not to intervene from their point of view, but here now it should be the eye should be salvaged. So that's why they have referred to us to salvage the eye. It was an acute presentation of thrombosis within 1 week.
Okay, so they didn't went for the coiling intervention.
No. Actually, the patient means he was slightly reluctant to do any procedure.
Okay.
So when he presented first, they have advised coiling. But when he presented to one department with full eye problem, his CCF was spontaneously closed.
Okay. So which anesthesia under this procedure was done?
Infiltrative anesthesia to the lateral side.
Okay.
Then after once the intraorbital pressure is reduced, I gave slight periorbital also to inferior crust. That's it. That's all.
Okay.
Lid margin, mainly infiltrative anesthesia, nothing else.
And supportive treatment other than heparin?
Other than heparin, anti-glaucoma medications mainly.
Which medication and why?
Here, this is mainly because of the episclenar venous pressure is increased. It's a secondary glaucoma. So ideally, when the cavernous fistula is closed, the eye pressure reduces to normal. But we can give like anti-glaucoma medications to reduce the aqueous pressure. Some drugs like prostaglandins also has helped in this reducing the episcleral venous pressure, though there is not much evidence. And now, recently the netazodil has come that they say it will reduce the episcleral venous pressure.
Okay, thank you.
Thank you so much.
Nice presentation.
Any visual fields you had done post-operatively? Any visual fields you did post-operatively? Patient regained 6/9 vision. Post-op.
Post-op, no, sir.
Okay.
He didn't come for the follow-up after 2 weeks because he was quite comfortable with his eye.
Now, quick, I'll just give you a quick heads up. Very nice case, very well documented also. But one is when you're presenting in front of, a judging section, everything has to be absolutely fine. So, the voiceover missing was not quite there. And the other thing is, the post-op results of everything, if it is well documented, then it closes the case basically. Otherwise, there are so many questions on it. Right? Thank you.
Now I would.
We have the best judge as possible. in India for this thing. Just take it as a learning experience, and this is the best stage to learn, and I hope you will win the best video in AOS. And I'm taking this opportunity to give a memento to Dr. Partha. Sir did a wonderful job as ARC chairman, and I was 3 times his LDP candidate, and if at all I'm doing something good, thanks to sir only. Sorry for interrupting, I just wanted to.
So 3 times LDP candidate, just imagine. Srini, had he been 5 times, what would have been KSOS?
Yes, this is here. Yes, he's uploaded. So not to be done.
Now I would like to invite Dr. K.S. Chandrakant to present a video on intraorbital foreign body measuring, 6 inches removal without anesthesia and investigation.
Good afternoon. Actually, the video was with the presentation was sent to the scientific committee, but they told there's a corruption in that video. So I'm giving a brief history. This is a patient, a boy, college student who came to my hospital around 7:30 in the night. That was a pre-Onam day. Onam in Kerala is celebrated for 3 days, and it starts on the pre-Onam day. And most of, especially we doctors, we take a 3 days leave on those 3 days. So you can't find any doctor in a hospital because we go on a tour, whatever it is. So this patient, he was little drunk because, as I said, Onam was celebrated within 3 days. First day, these people, college students, had gone for a tour or something like that, and they had drunk, and he was on the effect of alcohol. While driving 3 people in a bike, he was a driver. He fell down. There was a drizzles also. There was a rain. He skidded and fell down. Then his head hit the fence, and then he didn't know what has happened. Finally, this stick, a foreign body stick, entered into his orbit. He went to 2 medical colleges where he was seen by the residents. They were scared of seeing at foreign bodies, so they told there is no seniors here. There is no radiology department also working today because there are no radiology people there. So they sent him. He then went to 2 more eye hospitals. There also he was taken back. But then he came to my hospital. I had some 4 or 5 patients waiting in my OP room to be examined. I told him I'll finish that and let you know. And he was little drowsy. So I made the sisters, my nursing staff, put some antibiotic drops into the eyes and put some local anesthetic drops on the injured wound. Then after my cases, I examined the other eye, the same eye also. People was good, and because he was drunk and drowsy, I couldn't take a proper vision. But finger counting, he told me exactly what are the fingers which I told. Then I took a written consent because he was unable to give a written consent. His friends gave the consent, and with all such precautions, I attempted. I had a small experience of having removed such foreign bodies maybe 2 or 3 inches in the past. So keeping that in mind, I started. Then the video is to be seen. Yes. On. Volume. Just see that. See that. Just see that. The size of the stick. See that. It's roughly 8 inches. It was 8 inches. Then the suturing was done. The wound was sutured. Immediately I shifted him to the local hospital where my friend was there and told him to take the systemic part care. Then he was put on antibiotics for 5 days, intravenous for 5 days. And after 3 days, a CT scan was done. There was some soft tissue damages, no injury into the bones, or nothing was there. He had a vision of 6/6. This is wound shooting, that's all. Madhik, stop it.
That's a very interesting video. Do you also have an anterior segment a video post after all of this initial management was done? Because the entry of the wound appears to be oblique. So
Yeah.
it's my first impression looking at when you were pulling the stick out is that it's going to be a case of globe penetration as well.
Nothing was there. Nothing was there. No.
Were you able to get a video of the?
But then he didn't come to me after that. He ran away from the, because what has happened was his friends had taken a video and it went viral. So he was scared. And it came in the newspaper, local newspaper, or it came. And he was scared, and he asked me who took the video. I didn't take a video. I didn't take it. It's his friends who did that and spread it. And luckily, unlikely, they told my name also in the paper. Though that also came. If you want, I can show that also.
Chandrakant, excellent video, and I think you should name it Divine Intervention.
What about this?
Absolutely.
Yeah.
Because, getting back 6/6 vision from this is an exceptionally challenging video, a dramatic video, and I really wish that he had followed up with you properly, and it was not Onam time, and the pre-operative or the pre-removal workup, is something that is of great importance, because in such cases, you are absolutely blind to what amount of damage has been done to the globe, to the orbit. So at times it is a tamponade by the foreign body to any of the ruptures that the globe might have gone. So it can become catastrophic if that tamponade is taken out. So a full proper CT scan, ultrasound, as well as the evaluation of the anterior segment, and if visibility permitted, the posterior segment as well. And then the last would be, of course, removal of the foreign body.
Yeah, because in fact I spoke to, ranked 2-3 of my close radiologists to have a scan, but they are all out of station.
Yeah, I know.
So then I told him, see, this is the risk involved. If you want, I can do that, but I took a written consent from them. Then only proceeded. Then only proceeded. I took all safeguards, especially in this part of our state. It's very difficult. The medical, legal, and all is very, very difficult. It doesn't run on lakhs. It runs on crores. Any damages and all. I have taken all precautions. Yeah.
So I just wish for the scientific part of it. If all these could have been done, that would have really made it into a video which ophthalmologists would have viral. So very good.
Yeah. Thank you.
Now I would like to invite Dr. Divya Balakrishnan for our video simplifying complex diabetic retinal detachments.
At the outset, I would like to thank KSOS for giving me this opportunity. So I'll be playing the video. Diabetic retinal detachments are always challenging even for expert VR surgeons. This video demonstrates a step-by-step approach to these difficult cases so as to simplify it. The important step in diabetic vitrectomy is to release the traction by identifying the right plane of posterior hyaloid and the right plane for membrane dissection. After core vitrectomy, the first step is to release the anteroposterior traction by doing truncation, that is to separate the vitreous base from posterior. Small gauge vitrectomy cutter may be used to separate the posterior hyaloid by sweeping action by placing the cutter below the posterior hyaloid. Sometimes the dissection may have to be started inside out from the disc, especially in cases where the peripheral posterior hyaloid is very adherent. The fibrovascular polyp over the disc may be released using the forceps, and the cutter may be used to delaminate it by the rollback method. Cutter is being used like scissors for segmentation by lift and cut method. Use of suction to engage the membrane in the port for cutting. Subhyaloid hemorrhage may be removed by using cutter, vacuum, or by the reflex method. In this case of combined retinal detachment, all probe vitrectomy method is done where the cutter is used to do segmentation and to delaminate the membrane. Diathermy is used to make retinotomy, and fluid-fluid exchange is done in these cases of combined or tractional retinal detachment as the subretinal fluid may be thick. Look for second membrane around the center of a fibrovascular proliferation. It's important to identify this to get the right plane for dissection. A bimanual dissection using forceps and scissors is done here. Cutter is being used to create a plane by lift and shape method. A combination of outside in and inside out method is being used here. In this case of posterior closed funnel retinal detachment, the dissection is initiated from the disc in an inside-out manner. A bimanual dissection is being done here. A meticulous step-by-step dissection using appropriate instrument and technique leads to a successful outcome in these difficult cases.
Excellent video, Dr. Divya. So the membrane peelings. Now, what I wanted to ask is what your preference of gauge in cutting such sort of membranes is. Do you still use 23 gauge, or do you have you completely shifted to 25 gauge? Because
Of late, 10,000 cutters, because that has got a bevel edge, so that doesn't add. So of late I use 25 gauge 10,000 cutters because that has got a bevel edge, which actually helps in many cases. You do not use for scissors actually.
Dr. Divya, very nice video, and Piyush is the right person to comment on the scientific and technical aspect. What I would like to ask is, what do you wish to, give a take-home message from your videos? It is difficult in diabetic retinopathy, and the use of instrumentation, techniques, skills, patience, everything is very important. But what is the take-home message you're wanting to give to us from this video?
See, it's a combination of techniques which we have to use when you deal with these cases of diabetic retinopathy, and a pre-op good assessment actually, where in some cases you may have to plan for a bimanual dissection. So don't have a fixed idea that I'll go for only a 3-gauge, 3 ports vitrectomy. But as you see that the situation becomes difficult, you may have to switch from a 3-port to a 4-port, and then you may have to go for a bimanual dissection. So it's not like a single technique which you should be using, but it's a combination of technique depending upon the difficulty of the cases.
Right. So Dr. Divya, again, speaking from the perspective of AIOS, I wish this video goes into the finals and wins an award. So, but for that to happen, you have to, in that 8 minutes of your video, you have to say, step 1, this is where I did differently. Step 2, you have to be cautious, do it this way, and conventional steps might not be. And step 3, and at the end, they take home messages of your video. So, I mean, these are again very, very suggestions for you to, make it even better video than what it is now.
Thank you so much, sir, for that.
Thank you. Thank you.
Dr. Indu J. Nair, and to present a video on helping the pit heal.
I would like to thank KSOist for giving me the opportunity to present a video in this prestigious session. Thank you.
Helping the pit heal. Optic disc pit is a rare congenital abnormality of the optic nerve head, which usually appears as a grayish-white, round or oval depression of the optic disc with varying levels of severity. It belongs to a spectrum of congenital cavitary anomalies of the optic disc, ranging from morning glory syndrome to coloboma of the optic nerve. Histopathologically, it appears as a herniation of dysplastic retinal tissue into a collagen-rich excavation that can extend into the subarachnoid space through a defect in the lamina cribrosa. Optic disc pits are usually asymptomatic, but in about 1/3 of the affected patients, it may develop a macular cirrus detachment due to presence of subretinal or intraretinal fluid. The fluid from optic disc pit first creates a schisis-like separation of the inner retina and then reaches the subretinal space, creating a macular neuroepithelial detachment. The most common visual field defect reported is an arcuate scotoma. Central, paracentral, and germ scotoma have also been reported. This serial OCT and autofluorescence image belonged to one of our patients with optic disc pit maculopathy who was lost to follow-up. Over years, she has developed generalized RPE loss. So how do we manage such pits? Spontaneous resorption of fluid is possible in up to 25% of cases according to the various reports, but relapses are frequent. Several treatment alternatives have been proposed, including conservative management, laser photocoagulation, macular buckling surgery, gas tamponade, partial thickness retinotomy, and inner retinal fenestration. This 29-year-old lady presented to us with defective vision in her left eye. On examination, she was found to have optic disc pit maculopathy. She underwent pars plana vitrectomy. After performing core vitrectomy, posterior vitreous detachment was induced. Brilliant blue-green dye was injected. A fovea sparing internal limiting membrane peeling was performed. The peeled ILM graft was stuffed into the disc pit. Fluid air exchange was performed. %14 C3F8 gas was injected to replace air in the vitreous cavity. 6 months postoperatively, there is significant reduction in central macular thickness. The ILM grafts can be seen in the optic disc pit. At 1 year, there is very minimal SRF and restoration of foveal contour. This 14-year-old girl was diagnosed to have optic disc pit maculopathy in her right eye. Her central macular thickness was 1460 microns. She underwent pars plana vitrectomy. A scleral graft was harvested from the inferonasal portion. The harvested scleral autograft was placed in the disc pit. Fluid air exchange was performed. 20% SF6 gas was injected to replace air in the vitreous cavity. 6 months postoperatively, there is significant reduction in central macular thickness and the disc pit is sealed with the scleral autograft. At 1 year, there is absence of subretinal fluid and restoration of foveal contour. Both patients showed anatomical closure of disc pit, improvement in visual acuity, and reduction in central macular thickness. Patients with optic disc pits that are diagnosed incidentally should be counseled about development of optic disc pit maculopathy. They should be advised routine yearly follow-up. Although spontaneous resolution is seen up to 25% of cases, observation will generally lead to significant vision loss due to a lamellar hole, full thickness macular hole, or generalized RP atrophy. The most common procedure used, especially in the recent years, is pars plana vitrectomy. In this case of a coexisting disc pit with coloboma with nasal subretinal fluid, a drainage retinotomy is made to drain the fluid. Hence, modification in surgery like inner retinal fenestration, partial thickness retinotomy, disc margin laser, macular buckling, etc. will save the day. It is important to discuss with these patients that visual recovery is a slow and long process. Improvement in visual acuity were reported only after 6 to 12 months from surgery. In conclusion, treatment for optic disc pit maculopathy is warranted as majority of the cases suffer gradual deterioration with significant visual loss. Modifications in vitrectomy will aid in getting the desired outcome in such challenging cases. Thank you.
Excellent video. So how that scleral graft stays there?
Sir, it stays there, sir. It's the pit, that scleral graft is tucked into the optic disc pit. So, and after fluid air exchange, it stays there. We have not put fibrin. Actually, in literature, it has been shown
Yeah, it's
fibrin glue as
glue,
put.
yeah.
Yes, but we have not put a glue, and it has stayed there post fluid air exchange. And the post-op OCT, you can see that the patch graft is still there.
Okay.
Very nice video, Dr. Yendu.
Thank you, sir.
So, excellent surgeries. You've gone through the whole gamut of lasers as well as putting a free flap, plugging the hole, and very nice video of the scleral graft as well. Now, how often have you all encountered dislocation of the flap during surgery or even post-operatively? I'm talking about the ILM flap.
Sir, ILM flap, actually, in one case which we have seen, the flap has displaced, but we can still see that the posterior hyaloid removal, the maculopathy has come down actually, but the flap has been displaced. In one case I have seen.
That is the good thing about these cases, that they improve with almost all surgical techniques. The only problem is they tend to recur as well.
Yes.
So,
Yes.
and how many cases have you all done with the scleral patch?
So there are 2 cases, sir. In the past 2 years, 2 cases we have done with the patch graft. And the visual recovery, the maculopathy actually comes down very slowly. It takes 6 months to 1 year. So we should counsel the patient that it's not a sudden visual recovery you will get.
That is true. In these cases, optic disc pit cases, counseling has to be done no matter what procedure you're going to do.
Yes, sir.
I believe sir wants to ask.
What is the review of literature about the healing, the mechanism of stuffing the optic disc pit? The scleral graft has been reported in the literature previously also.
Yes, sir. Yes.
Any innovation that you could think of would be beyond the scleral graft? Anything that you could think of or you could have tried?
Sir,
Surgically, what is more easier to do, the ILM graft or the scleral graft?
ILM graft, sir. ILM graft, because scleral graft, when we take, it has to be, whatever the size of the graft we take, it has to be again more like fashioned to get it stuffed into the disc pit, because there is high chance of displacement. So in that case, we have to put fibrin glue. But luckily, in this case, it was staying.
Right. Thank you very much.
Anybody watching also, well, like the surgeons over here were very good, so they did not use any stabilizing agent to keep the flap in place. But people also use rarely PFCL to stabilize it. People use a little bit of viscoelastic also over the ILM flap so that it doesn't dislodge.
Dr. Yashovardhan Sivaj presenting a video on virtual reality assisted teaching of ophthalmology in MBBS.
Good afternoon, sir. Thank you for giving me this opportunity. I would like you to watch my video. Can you arrange the volume?
Now, what if I were to tell you that you need not be an astronaut to explore the fascinating realms of space anymore? What if I tell you you need not shell out thousands of rupees for experiencing the beauty of that very place which has always been on your travel bucket list? What if you could observe the wild up so close? If all of this sounds exciting to you, then let me introduce you to the fascinating world of virtual reality and its possible applications in medicine over the next few minutes. Virtual reality is a simulated 3D environment that enables users to explore and interact with the virtual surrounding in a way that approximates reality. Virtual reality has found its applications in many fields, including but not limited to war zone simulation for army training, architecture and civil designing, video games and entertainment, medicine and surgical training. So how does one enter the 3D virtual world? Well, all you need to do is wear a VR headset which covers your eyes all around and displays the same image but from a different perspective in both our eyes. When our binocularity kicks in, we get to sense the depth of this virtual world. Just like how in this video the roller coaster is shown in each eye, but with a different perspective of the same video is displayed, and that's what helps in creating a three-dimensional video. These headsets also do have a built-in gyroscope which senses the movement of your head. We all have had lectures in our colleges till now, and there is no denying the fact that our professors have always had this magical aura surrounding them, which makes the toughest topics seem easy after the lectures. But now in 2022, we definitely can, and so we should, take the aid of technology for the same. The traditional methods of teaching rely a lot on imagination, as well as how well a person can understand the drawings and the diagrams, which are often used to explain the anatomy, be it at a macro or a micro level. But if we were to add the third dimension and a lot more to our teaching and learning method, the end result, it would be a multi-sensory stimulation and experience which would be way more beneficial than the current methodology. Virtual reality thus allows a multi-sensory interaction with the virtual environment, thereby making it an ideally suitable tool for effective learning and understanding of the intricate details of ocular anatomy. So with this idea in our mind, we started on a journey of creating a three-dimensional virtual reality-based anatomical model of the eye. The 3D model of the eye was made using a CAD software called Autodesk Inventor, wherein initially all the individual parts were designed and then later on they were assembled together into one form. Rendering of the same was done using a software called Blender, which gave the eye model a very realistic appearance. Finally, Unity was used in order to make our model compatible with the virtual reality world. Our primary aim was to make the model as anatomically correct as possible while making it appear very realistic. Not only this, but color coding was such that the model could be relatable to the images seen in textbooks, and thus that correlation was ensured. Finer details like placement of the trabecular meshwork, the Schlemm canal, extraocular muscle insertion, etc. were also given due importance. Then it was time to introduce the students to this virtual world. After a brief class on the topic for the day, the instructor wore the VR headset and took the students for a tour around the eye, explaining the importance of all the structures and relevant clinical aspects. The students were able to see what the instructor was experiencing on a display screen. Later, the students also got hands-on experience with the VR headset and were able to navigate their way around the eye. Relevant clinical aspects like various mechanisms for open and close angle glaucoma, for example, were displayed just beside the 3D model of the eye as seen here in the window, which gave a very good comparison of anatomy in health versus pathology in real time to the learners. Potential uses in the foreseeable future include the use of haptics to create surgical models of the eye on which training the residents will translate into a better understanding of the surgical technique. Haptics offer an entire dimension to a virtual reality or 3D, and it basically provides a way to translate our movements in the physical space into our movements in the virtual space, thus developing skills like that required for a continuous curvilinear capsulorhexis, for example, and can be initially learned over the 3D model before providing to do the same on a patient. With the availability of VR headset at a price starting from 500 to 800 rupees, the future definitely holds a space for the various applications of VR and the possibilities of the same are endless. In the end, I would like to quote what Morpheus said over 18 years ago in The Matrix. Have you ever had a dream that you were so sure was real? What if you were unable to wake from that dream? How would you know the difference between the dream world and the real world?
Thank you for your attention, sir.
Yashwardhan, I mean, we are all very keen to know how you developed it. It was a development that was done with your ophthalmology department with the team
Center, yeah.
who
Yes,
worked
sir.
on the logistics as well as on the technicalities. And at which stage of the anatomy are you? Because after the anatomy will come the diseases,
Yes.
and after
Yes,
the
sir. Yes, sir.
diseases will come also the process of the surgical process, the management processes.
Yes, sir.
So,
Basically, this was the brainchild of my professor and HOD, Dr. Gopal sir. I'm from Amrita Hospital, Kochi. And in our hospital, apart from our department, there is a separate 3D lab, which is the initial in the video. Initially, there was some sort of a heart that was being pulled out from the chest, is what is already being followed in pediatric cardiology department, because various complicated cases, they want to see it before they proceed to surgery in real life. So with the help of that department, and of course guided by Gopal sir, and I and one more software engineer was there. I would be telling him about the details and how the anatomical structure should look like. Although this is the first time we all are trying for it, so certain things did not match our expectation, but we are still working on it. As of now, if you could see in that video, the retina part was not as developed, and I was initially focusing to get the anterior segment right as much as possible. And our future aim in this is to first complete the basic anatomy of the eye correctly as possible we can display. And the other thing is that we would want to, we ideally would want a scenario wherein a person can just walk into that eye, and they'll have some pointers there. For example, if they see some superficial hemorrhages and narrowing of arterioles, they can just click there and that will tell you about the pathology. And the clinical picture, autofluorescence, fundus fluorescein angiography, OCT, relevant anatomy should be displayed just at a click. So that is what we want to develop first at our first phase. And the second phase would definitely be to include the haptics along with this. And haptics, what extent to which haptics can help is that it won't replace surgeries definitely, but things like a continuous curvilinear capsulorhexis, which requires sort of feedback also, that can be given easily. And that has been done other places also. This is just an indigenous thing that we are trying to do.
What about the validation? So how you are validating these things?
So regarding validations, the thing is, regarding sir, MBBS teaching validation, are you asking about all the software? Because once a part of the eye is developed completely, like let's say anterior segment is completed, then we plan to conduct an MCQ based exam. MCQ based exam on people who have been taught the same topic using presentations and in classes in the same batch. Batch would be 50-50, like 50 people will be teaching through the traditional method versus 50 people who had access to this too. It's like an additional. We cannot, as I stated in my video also, we cannot replace traditional.
So is it randomized or?
That we'll be planning on, sir. Yeah, that study is pending and we have to do. Actually, I'm in my final year and there were many other things that are going on.
It's under patent?
Yeah. Sorry, sir?
Is it under patent?
No. As of now, no, because it's not complete yet. Once it is complete and we can publish some paper about it, that will be very great.
Okay, thank you.
Very innovative. Kudos to all of you.
Thank you, sir.
The one difference I think that in your second stage, what you all are planning is to, the haptics. With regards to the haptics, you already have some very nice models that are available. They're not that expensive. They can be used multiple times for doing CCCs, for doing phaco's, for doing vitrectomies, for doing ILM peels. So those are very much available, but probably this would have an advantage is if it can give you feedback as to where you're going wrong.
Yes, sir.
Then I think that would make a definite difference.
Yes,
for
sir.
sure.
Yes. Definitely. We'll try for the same.
Very good.
Thank you, sir. Thank you, sir.
So just on curiosity, how long is it going to take you to develop the aesthetic structural
Aesthetic part is
component
almost complete because initially what we were doing is to make the vein and artery like in an animated format. But now what we are doing is that we'll paste in images, real life patient images that will be superimposed in the retina, like maybe ultra wide field image that is superimposed inside. So wherever you look, it's like you're looking at the real retina inside. So that is our plan. So that has speeded up our process a bit.
So regarding the patient counseling, is it also in the pipeline?
Sorry, sir?
Patient counseling through
Patient counseling through this can be done, although it might be a bit time consuming, and as in the video, what I was experiencing was only experienced by the students after I showed them initially and then handed over the headset. So that is, it can be done successfully, definitely, especially in patients who are, want to really know what is going on with their, and not convinced, maybe. Not convinced with your paper drawings or model-based things. They can definitely see this. And if we include the videos of the surgeries that have been done already on similar case scenarios, for example, macular hole surgery, if they want to see a surgery going on in 3D also, that is also a good option.
Okay.
Thank you. Thank you, sir.
Now, Dr. Suga Ranjani, tenants to the rescue. Okay. So last video from Dr. Meena CK, unveiling the curtain to sight.
Good afternoon, everyone, and thank you for this opportunity.
Spotlessly clear vision is a desire of all. Though in reality, a few are denied the same, some due to natural causes and some as a sequel to various procedures and ailments. Presenting a few video clips demonstrating the unveiling of the curtain of sight. Persistent pupillary membrane. Persistent pupillary membrane is not a rare situation. But when it reaches such a proportion, it can be vision threatening. Managing it needs utmost care as the lens capsule is a vulnerable structure in close vicinity. Fine filaments could be released with iris repositor swipe. But the central adhesion resembling a pterygium head not yielding to removal with a microforceps. Repeated attempts brings only in piecemeal. Thus, lifting it up from the exact cleavage solves the issues. Removal of the released tags from the iris surface exposes the near normal pupillary sphincters. The end result, a clear visual media. Though a few pigments remains on the lens surface, you get a good red glow on retroillumination. occlusio pupillae. Total posterior synechiae, with the patient unaware of what procedure was done in the childhood. He had reasonable vision for a while, but missed follow-ups. Entry into this wall compartment is difficult, but retro-illumination makes it less cumbersome. An opening with micro scissors followed by vitrector helps in the membranectomy, exposing the hidden intraocular lens. Some of these adhesions are extremely thick and vascular and may not yield to anterior vitrectomy. Bleeding from these adhesions calls for a change in strategy by enlarging the visual axis by a pupilloplasty, by combined efforts of a vitrector and micro scissors. The pupil is thus opened up and shaped with the help of the anterior vitrector, the end result being an exposed intraocular lens and a clear visual axis. After cataracts, it's a common occurrence post-pediatric cataract surgery. It needs early interference lest they go for amblyopia. This child has a good anterior and posterior capsulotomy, but the loose after cataract was blocking the visual axis. It is easily cleared with dry aspiration followed by a gentle anterior vitrector. When the shepherd himself eats his flock. Opaque IOLs. Opaque IOLs are rare scenarios and it demands replacement. Additions between the capsule and the intraocular lens need to be expected here. Here, the tip of one haptic is stuck onto the capsule, and cutting out the haptic at the attached area is ideal, or else pulling on the capsule can compromise the capsular bag and the opportunity for a safe sulcus IOL. The other haptic will easily slide out and the intact capsular rim is visible with enough support for a sulcus IOL. And now here you see a well-centered IOL which is placed in the sulcus. The only thing worse than being blind is having sight but no vision. Rightly said by Helen Keller. Thank you for your patient viewing.
Dr. Meena, very nice concept, and you know, your initial videos which showed the technique of using the vitrector very judiciously making an opening quite atraumatically, and that's definitely a very good thing that you highlighted. One question, if I can ask you, is about the last case that you showed, the opaque IOL. So the absolute right learning point here was cutting that haptic and severing it and coffining it in the capsular bag itself. So it is in a coffin, it will not intrude even if you have another IOL in place. So that was an excellent, without tugging it out or trying to remove it in toto. But the other thought that I would have is, you had to make quite a large incision, and whereas you could have sacrificed the length of the incision and made it smaller and cut the haptic optic just midway, up to the midway, and swivel the whole optic out. So that could be another technique, and you also left the wound unsutured. So quite a large wound, maybe a suture would have a better option of the stability of the wound itself. And of course, if the wound was small, say 2.8 or 3 millimeters also, so unsutured, definitely you can leave it.
Thank you, sir, for your advice.
Thank you all.
Thanks a lot, and thanks a ton for these great guys for actually mentoring. See, I was just talking to Prithvi regarding mentoring process. So this was effectively a mentoring that has happened by the best people. Imagine the scientific committee chairman of AOs being there, sitting for the judging the videos. This is probably the highlight for me for this conference. So thanks a lot, sir. Thanks a lot. And we are there with you. Any project that I promise you on behalf of KSOs, we are there with you.
Fantastic, Shri, fantastic. Thanks a lot. And it's been learning for all of us. I'm sure even Piyush with all those diabetic retinopathy, I'm sure you don't do as good as that. What Shishir showed, and excellent, excellent. Very, very good videos. Vanashri's was excellent as well. All the videos were very good. Okay. So I just want a small, again, what Srini, if he makes me a mentor, then I have to tell you that one or two things that you definitely must do right. Where a video wins an award. I would really like to tell you that you must go onto the website where the best awards are, the best first, second, third. They might not have the strongest scientific content, but the presentation is mind-boggling. So a mind-boggling presentation draws attention. You have to have scientific content. So scientific content, if it is there, the presentation has to be equally or even better. So that is where the marks flow in. The other thing that I always believe is your title. Title should be such that it should grip, oh, what is this guy going to say? Something like that. So that again is, most of you people know people who are judging those papers and abstracts, and I keep on sending hundreds of abstracts to all the senior people. And when somebody is judging an abstract out of 150 abstracts on cataract, it is becoming, oh God, wow, another one, another one. So what rivets the attention is the title, and then of course, crisp quality content. So that is where you stand a chance. And unfortunately, because at AIOS we have such a huge number of submissions, and unfortunately if you see the statistics, we are rejecting nearly 75 to 80% of free papers, which is such a sadness for all of us. So then we put them into poster category, etc., etc. But again, that 20% is the cream of India, absolutely. So how do you get into that cream? And that 20% mark is the title, how you give the abstracts, how you submit the abstracts. And the third and most important thing is the last date of submission is always mentioned at the bottom of the abstract. Please, please don't wait for that last day and that last hour of midnight, because those abstracts which come in the bottom line, they might be extremely good, papers might, but the evaluator is wading through so many, and then he comes. So immediately submit the abstracts as soon as it is announced. So points that I really wanted to share with you. Thank you very much.
Yeah, sir. You got the best advice. Okay. Thank you, sir. Thank you, Arvind. Thank you, Piyush. These are great people. Whatever help that we can give them, we are going to give them. Right?